Our final session for the day will be a symposium on pediatric mood disorders. I would like to kindly call upon Dr. Swarna Wijetunga and Professor Harshini Rajapaksha to chair the session. Over to you, Madam.
Good evening. It's our pleasure to come to the last session for the day. It's about child psychiatry. I'm happy that I'm chairing with Dr. Professor Harshini Rajapaksha. She's going to introduce the speakers, and we'll start the session now.
First speaker of this session is Dr. Aditya Sharma. Dr. Adi Sharma is a clinical senior lecturer and an honorary consultant in child and adolescent psychiatry at Newcastle University and Cumbria Northumberland, Tyne and Wear NHS Foundation Trust. After completing his medical training and postgraduate training at Delhi University, Dr. Adi moved to Newcastle and retrained in clinical academic child psychiatry, getting his PhD at Newcastle University. He leads on the National Specialist Adolescent Mood Disorders Service, which gets referrals from child psychiatrists across UK seeking a second opinion regarding a complex and hard to manage mood disorders. He also leads on Northeast England South Asia Mental Health Alliance, which has partners in Sri Lanka. So over to you, Dr. Adi.
Hi there, good evening. It's Adi here. Apologies for my video not working very well, but that's partly because I'm actually in Mexico and on holiday at the moment, and the bandwidth isn't great. So I hope you can all hear me. I'll start to share my slides. Thank you so very much for inviting me. A huge thanks to my colleague, Dr. Udena, for recommending me to the Sri Lanka College of Psychiatrists. And, my thoughts go out to all of you in the country at the moment. And I really hope the situation, continues to improve. So in the interest of time, I've been given 20 minutes and I'll try and stick to that. So we're going to talk about depression in children and young people under the age of 18 and what to do when SSRIs don't work. I will try my very best to stay on until the end. I'd love to hear how things are being managed in Sri Lanka. We are a bit limited in the UK because of, some of you might be familiar, because of the recommendations by NICE. So what I hope to cover today very quickly is, why me? Why am I being asked to present this? A quick catch up about unipolar depression, and then what NICE, or the National Institute of Clinical Excellence, recommends for when fluoxetine doesn't work in the UK, because gold standard practice in the UK is to treat depression in under 18s with fluoxetine first line. The concept of difficult to treat depression, or when two management strategies haven't worked, including preferably 2 pharmacological and 1 psychological intervention, what was previously conceptualized as treatment-resistant depression, and then move on to what if 2 SSRIs don't work. So I guess the question is, why me? I am, as Professor introduced, I lead on a national second opinion service. This is called SAMS for short. We love our acronyms in the UK. Everything has to have an acronym. So I receive referrals, and that's where we're based. We're in the northeast of England. It's a beautiful part of the world. And we, as you can see, we are in the middle of the United Kingdom. And exactly at the same level almost as Northern Ireland. So we get referrals from across the country, and that does mean sometimes for the team a lot of traveling involved to go and see people. Although I think with the silver lining to COVID has been the advent of of being able to see people remotely via Teams now. The other reason, I suppose, is the mention of the Northeast England South Asia Mental Health Alliance, which we developed in 2018, and it continues to thrive. Please do consider signing up. There is no cost involved. And we are trying to work together with partners in South Asia, which includes Sri Lanka, of course, to improve research and training across the lifespan, really, in mental health. So that includes children, young people, adults, and of course, the elderly. So I have a particular interest in this field, as you can gather. In terms of unipolar depression, the quick update, and I say this particularly to lots of trainees, is going back to basics, which is, and I'm sure that in Sri Lanka people are more particular about this, but in the UK people often forget that depression has to last at least 2 weeks. Even in kids, it must be present for at least 2 weeks, and there must be these 5 or more changes. I'm not going to read them out to you because that would be rather patronizing, and I know it's late in the day for you all. The important thing I just also wanted to mention, though I haven't got it on the slides, is I'm sure you're all aware that with the ICD-11 that has come in, particularly relevant for children and adolescents, now for even moderate depression, one can have psychotic features present. So classically, it was always thought that severe depressive episodes only can have psychotic features. But in the ICD-11, even moderate depressive episodes can have psychotic features. And I think we need to bear that in mind, especially for young people. So, first of all, I'll cover what NICE says about beyond fluoxetine, because as I mentioned before, the gold standard is fluoxetine, and the way NICE appraises the literature is that it reviews all the literature and the maximum number of studies for child and adolescent depression are in with the use of fluoxetine. Hence it being the gold standard. And what NICE basically recommends is that for depression that is unresponsive to treatment, or recurrent depression, or psychotic depression, at levels tiers 2 and 3, there should either be individual CBT plus or minus fluoxetine, and if shared decision-making indicates that these needs are not being met, one can try one of these other interventions. Now that's very limited, because actually NICE says very clearly, if fluoxetine isn't working, then you can try other agents, but it really just limits you to sertraline and citalopram. In fact, those are the only other agents that are commonly used in the UK. I want to introduce to you the concept of difficult to treat depression as opposed to treatment-resistant depression. So for a very long time, we have identified disorders as treatment-resistant. But if you look at it from the perspective of the patient, it sort of tends to almost blame the disorder or the patient, possibly at times, for holding out and opposing. Whereas difficult to treat depression is a much more collaborative concept, which brings together the patient, the family, and the physician, that we appreciate that this is a difficult to treat condition. It also takes away from that acute illness model that works very well in physical health, but doesn't, as most of us know, work very well in the mental health field, and takes it more to a chronic biopsychosocial model, which focuses not necessarily on cure, but on optimizing symptoms and minimizing the impact of these symptoms. There's a very helpful paper that my colleague, Professor Hamish McAllister Williams, has written the Journal of Affective Disorders. So the principles of difficult to treat depression, and I would really put in a plea and to all of you, is that if you are struggling to treat any disorder in young people, not just depression, I think the keystone has to be, and thank you to the previous speaker who reminded us that, you know, comorbidities are pretty much the norm in mental health, particularly the extremes of age with young people and the elderly, is to reconsider your differential diagnosis. And then identify and treat any comorbidities. And this is really important when it comes to young people in particular. And then think about formulation, you know, a more detailed formulation, thinking about the predisposing, precipitating, and perpetuating factors. And I appreciate that this is old hat. I'm sure you're all doing it, but really, really important. And the reason I say this is that when we get referrals into our service for depression and or bipolar, the question we're always asking is it actually depression or bipolar that is being treated or something else? In young people, particularly in depression, the challenge often is there a comorbidity of autism spectrum disorder? And then the impact of trauma, particularly early life adversity, and the really helpful new diagnostic entity of complex PTSD. We can't go into the details of that, but again, just want to emphasize the importance of considering that both in the differential diagnosis, but also including it in the formulation. And then, of course, the concept of emerging personality disorders, trauma and life adversity sometimes can impact so severely that young people are presenting with those features, and they may or may not have depression on their own. It could be depression associated with personality issues. So moving on to the three-dimensional assessment, and again, this is something that you're all familiar with, thinking about the person factors, so personality, genetics, childhood trauma, and the psychosocial environment. The illness variables, such as diagnosis, is this depression or bipolar, or as I mentioned, something else entirely. The age of onset and the chronicity, the use of substances, and then the number of treatments that haven't worked. What are the nature of treatments that they've been on? And most importantly, adherence to treatment and tolerability. So apologies for this very, very busy slide, but this is a really helpful thing that takes you through the way to approach difficult to treat depression. And this works across lifespan, by the way. It isn't just for children and adolescents. But moving on to the first bit, which is achieving optimal symptom control, using conventional treatments first of all, which include medication and psychotherapy. If medication, whichever medication they're on, it is working in a limited manner, then you could consider increasing the dose, switching or augmenting. We'll talk a bit more about this. And of course, high-intensity psychotherapy with or without medication. And then we could move on to the use of non-conventional treatments. And the evidence base for this is extremely limited in children and young people. So focusing on the first bit. So if fluoxetine doesn't work, coming back to NICE, sertraline and citalopram in the UK should only be used when the following criteria have been met. That is, the young person and their parents or carers must have been fully involved in discussions and must have been provided with appropriate written information. And the child or young person's depression should be sufficiently severe or causing sufficiently serious symptoms to justify a trial of another antidepressant. And the written information should cover the following details in it, which is really important, because medical legally there have now been instances of NHS trusts being taken to court for failure to provide this written information as part of any change in medication. It also recommends that if treatment isn't working, and this is coming back to the concept of difficult to treat depression, to reassess the likely causes of depression and for why the disorder is proving difficult to treat. For example, there might be other diagnoses such as bipolar disorder. So what you're seeing is difficult to treat depression, but the reason the SSRI isn't working is that maybe it is actually bipolar disorder rather than unipolar depression, or substance misuse. In the UK, the advice is that because we have non-medical prescribers now, nursing colleagues, psychologists who also prescribe medication, that there must have been advice before switching from usually a consultant in child psychiatry. And the young person must have signed an appropriate and valid consent form for switching medication. Now, unfortunately, NICE guidelines are they're very prescriptive, and I'm not sure how many of you are familiar with the NICE guidelines for depression in under 18s, but they actually state very clearly, based on the evidence, that do not try venlafaxine, do not try mirtazapine, which sort of limits you to 3 SSRIs. And really, after 2 SSRIs, our advice, and this is sort of expert consensus rather than evidence-based, RCT-based data or a network meta-analysis, is that after 2 SSRIs, if there's been minimal response to the SSRIs, consider switching to venlafaxine. But I must remind you all that this is not in keeping with NICE guidelines. And then if there has been a partial response, but not sufficient, you could consider augmenting. And here I bring you to your attention the British Association for Psychopharmacology guidelines, which state that the first line intervention should be considering adding quetiapine, aripiprazole, or lithium. Second line should be risperidone, thyroxine, or mirtazapine. And then third line could be the following agents. I would like to just, this is based on adult data. And again, there are few studies, even in adults, with augmentation. So it's mainly based on case records and audits, which, as I'm sure you're familiar, a lower level of evidence base. In children and young people, the general consensus is augment with either mirtazapine or lamotrigine, because those are better in terms of their side effect profile and response. And definitely, avoid antipsychotics that would cause a lot of metabolic side effects, which we see a lot of in the UK. So in summary, you'll be glad to hear I'm at the end. In summary, depression, as I'm sure you all gather, is a heterogeneous condition with frequent comorbidities. If there is no response to a trial of 2 SSRIs, please consider reassessment and reformulation. And if using management out with treatment guidelines, please take a shared decision-making approach with the patient and the family, and seek out a second opinion. Even within Sri Lanka, I'm sure you could seek out an opinion from a tertiary center. And if that, it doesn't mean a formal referral for the family, but you could, in a peer supervision way, discuss that with a senior and more experienced colleague in that area. So I just wanted to say a huge thank you for inviting me. That, by the way, is the QR code for the NISAMA website. I hope some of you will scan it. Please join us. And I hope that, in the not so distant future, we can hold an event in collaboration with the Sri Lanka College of Psychiatrists in Sri Lanka. So thank you very much. And I'll stop screen sharing and hopefully allow the next speaker to stay. And I'll try and stay till the end. I'm afraid it's very early in the morning here, just gone 6:30. So I'll try and stay in the end to answer any questions that you might have. Thank you.
Thank you very much, Dr. Sharma, for accepting our invitation and delivering this very comprehensive lecture. And questions will be taken at the end. I would invite Dr. Swarna Wijetunga to introduce our next speaker. Over to you, madam.
Next speaker, Dr. Nilanja Valsaperuma. She's a consultant in child and adolescent psychiatry attached to Colombo North Teaching Hospital, Ragama. She has completed advanced training in child and adolescent psychiatry, University of Melbourne, Australia. She provides advocacy towards mental health well-being in children and adolescents in Sri Lanka, and she has special interest in childhood mood disorders, developmental trauma, and social psychiatry. Over to you, Nilanja.
Thank you, madam. Distinguished guests, my dear teachers, colleagues, friends, good evening. First of all, I would like to thank the Sri Lanka College of Psychiatrists for giving me this opportunity today. So, greater understanding of childhood bipolar affective disorder came with work done at Lady Ridgeway Hospital for Children with Madam Swarna Wijetunga. So today I would be focusing more on diagnostics rather than the management. So, as we all know, bipolar affective disorder is characterized by multiple mood shifts during the course of the lifetime. And the diagnostics is carried out by classifying patient experiences or observable behaviors according to DSM or ICD. Interestingly, when it comes to the diagnostic evolution across a century, starting from 1921, Emil Kraepelin coining the term manic depressive insanity, we have evolved very little, where we are talking about bipolar affective disorder in 2021, according to phenomenology. So, with that food for thought, let's go on to epidemiology and the burden. Prevalence in the UK is about 22% of the population, and in US about 2.8%. And with global data extrapolated, let's say we have around 200,000 population in Sri Lanka. So suicidal rates estimated to be over 10%, and suicidal attempts at 34%. And there is a large healthcare burden. Going on to etiology, there is a 10 to 25% increase in tendency to develop bipolar affective disorder with a first-degree family member. Heritability stands at about 70 to 80%. The genome-wide association studies have found multiple candidate genes, and indeed, it's multifactorial. So you have multiple risk genes with multifactorial insults, usually early life insults, trauma. You have these risk genes undergoing epigenetic changes. With a second or third hit, these disordered genes would express themselves to have the disorder being manifesting. So when it comes to parents with bipolar affective disorder, attachment disruption and trauma has been quite common. Attachment disruption has been significantly seen in adolescents with a parent with bipolar disorder. And conversely, adults with major psychiatric illness have had significantly higher rates of attachment disruption. So, disrupted attachment would give rise to a perfect niche for these genetic manipulations to occur in vulnerable children and adolescents. So, when it comes to trauma, young individuals at high familial risk had shown significantly greater frequency and severity of physical abuse when compared to healthy controls. And in this study, they had also displayed greater severity of prodromal symptoms than the other groups. And youth with bipolar disorder and familial risk had shown greater levels of child trauma exposures. So these are amounting to child trauma. So this slide is actually laden to say that it's high time that we go beyond phenomenology and diagnosing patients with their experiences. The neuropathological process can be translated into phenotypes, and these combinations can be utilized in diagnostics. Going on to age at onset. This is one of the largest studies done, the STEP-BD, the Systematic Treatment Enhancement Program for Bipolar Disorder. They had studied over 3,600 patients with bipolar disorder and found that 30% had had prepubertal onset, and 68% had had their onset by 18 years. And this had been replicated by this study as well, the NIMH Bipolar Disorder Genetic Association. A similar pattern is seen. So what is this fuss about childhood bipolar disorder? It is a master of disguise in its presentation. It can be hidden between many diagnoses fulfilling syndromic criteria. And one needs careful examination at the onset, the evolution, response to medication, and identifying dimensions in order to come to a diagnosis. Why is it important to diagnose early? There is a greater loss of recovery, greater disease burden. It's estimated that over 5 to 10 years are lost prior to diagnosis. And each lost year has been calculated to have about 10% capacity loss. And there's been noted to have greater harm with use of antidepressants. They're noted to be in less time in euthymia, noted to have more recurrences, high suicidality, greater substance use, and more functional impairment. And they are more likely to have been through childhood trauma, a parent with a mental illness, multiple comorbidities, therefore beyond treatment for same, and which would confound the diagnosis, and they would have been misdiagnosed and mismanaged. So I would like to lay down here a case experienced at Lady Ridgeway Hospital for Children. Miss D, 13 years, an intellectually normal child with a history of intra-uterine and growth restriction. She received 7 diagnoses over 5 years. OCD, trichotillomania, ADHD, ODD, going on to conduct disorder, binge eating disorder, recurrent depressive disorder, and emerging borderline personality disorder. So the onset of symptoms was at 8 years. She was a terror and a joker in the class. She had frequent meltdowns at home. Extreme anxiety with obsessions and compulsions, took 4 to 5 hours a day. She would binge eat in the evening latterly, and there was a sudden need for sleep in the class, and she would sleep late. She would sleep late with nightmares. She experienced frequent suicidal ideation. There was a significant functional impairment, and she was on multiple psychotropes. And she was extensively investigated, including neuroimaging and endocrine workup. So this is a kind of a pictorial representation of the course of her illness and how the diagnosis evolved over time. So her course of illness was reviewed to minute detail, identifying responses to escalating antidepressants and stimulants. She displayed manic and depressive symptoms, although they did not meet duration criteria. We identified extreme sudden daytime sleeping and nighttime reduced need for sleep as circadian rhythm disturbances. We identified binge eating as an appetitive drive disturbance and identified that oppositional defiance is upon protecting territory. She did fulfill criteria for mania, although she did not fulfill the duration criteria. So she was diagnosed with childhood onset bipolar affective disorder not otherwise specified and commenced on a mood stabilizer while omitting all her medications. Her mood symptoms resolved within 2 to 3 months. Interestingly, her anxiety disorders, including the OCD and trichotillomania, remitted. She was no longer hyperactive, so no longer met criteria for ADHD. She no longer binge ate, so no longer met criteria for an eating disorder. She was no longer oppositional or defiant. Her CGAS scores rose to 70 to 80. However, some deficits continued, including executive function difficulties and peer relationship deficits, and she has been euthymic since. So, when it comes to the diagnostic entities in childhood bipolarity, in relation to the classifications, you do find bipolar 1 fulfilling criteria for mania, for the duration criteria. And you do find children fulfilling criteria for BP2, including the duration criteria. However, there is a majority, I would say, who would not fulfill criteria, especially the duration criteria. They may display cycles as short as 4 hours and may have multiple cycles during the day. So commonly what we see in our practice is that we see children are within the depressive pole in the morning and would fulfill criteria for mania or hypomania during the evening hours of the day. And these alterations are conceptualized as cycles within a mood episode. So the stability of the diagnosis of these children who are being diagnosed as bipolar disorder not otherwise specified, there has been studies which showed that the children had the same symptom burden and functional impairment throughout the course of the illness. So the difficulties in diagnosis of child bipolar disorder comes with trying to meet the symptoms with adult experiences laden criteria. So it also comes with having a comorbid diagnosis is usually the norm rather than the exception in children and adolescents. And they commonly have other neurodevelopmental and biological deficits which will have their own behavioral manifestations which would cloud the diagnosis. So I will try to touch upon some of these diagnoses. Attention deficit hyperactivity disorder is quite common. Literature speaks of having 50 to 70%. Our research also supports this. They have a likelihood of earlier onset, prevalence of other comorbidities, worsened course and prognosis with greater suicidality and substance use disorders. When it comes to anxiety, adult patients, over 14,000 adult patients had been studied and had shown over 45% have a syndromic anxiety disorder. Obsessive compulsive disorder criteria met 23% of those with bipolar affective disorder. Obsessional and compulsive symptoms meeting syndromic criteria, interestingly, may absolve when the mood episode settles. Higher OCD and hoarding prevalence rates are seen in children. This was again seen in our research. They may arise with an acute onset, with a significant symptom burden, and they may show rapid response to antidepressants. And again, greater symptom burden during the course of the illness with a poorer course and poorer functional outcomes. Oppositional defiant disorder usually may not meet criteria once a mood episode settles. Autism spectrum disorders, about 8 to 10% would develop bipolar disorder. And they may have early onset of mood symptoms and a larger symptom burden with elevated rates of comorbid obsessive compulsive disorders again. They may show social withdrawal and low reactivity of negative mood states. Children and adolescents with autism spectrum disorder commonly display perceptual abnormalities. They have perceptual processing, sensory processing difficulties, which would complicate the picture when it is comorbid with bipolar disorder. We may treat them as psychotic disorders. And between 12 to 20% of autistic individuals may have catatonia-type deteriorations, where they may display bradykinesias, difficulties in initiating and following up of activities, reduced speech, regression of skills. And our experience has shown that these individuals have catatonic symptoms comorbid to bipolar disorder. And the presence of these catatonic symptoms may confound the presentation of bipolarity. So they commonly have other neurodevelopmental and biological processors, deficits in processors, like cognitive deficits, commonly have executive function difficulties. They can have sleep deficits with nightmares and other parasomnias. They can have motor regulation, coordination difficulties. They can have thermoregulation difficulties, which has been studied as a biomarker for a certain phenotype of childhood bipolar. And they have commonly sensory processing difficulties. So the behavioral manifestations that would occur with these difficulties would confound again the underlying mood disorder. So with all of these difficulties coming in, it is recommended that children and adolescents should be diagnosed beyond the categorical diagnosis that we usually employ for adults. So a dimensional approach to the formulation is highly recommended. So the dimensions are invariably the manic, hypomanic, and depressive symptom dimensions, and to study for look for appetitive drive disturbances, like eating habits, hypersexuality. Then look for circadian rhythm disturbances. Identify differences or psychomotor activity levels and energy during the course of the day, whether they fit into a pole where the child may be depressed or manic or hypomanic at some point during the day. Then look for anxiety-related dimensions, including obsessionality. We may have to tease out complex PTSD because trauma is quite common in these children. Other comorbidity assessment and patterns in symptom burden, neurocognitive dimensions, and other developmental and biological deficits. So going within a formulation that encompasses a dimensional approach would gear us towards a diagnosis. So the Child Bipolar Questionnaire has been validated to the Sri Lankan population with excellent sensitivity and specificity. So it's provided free of usage for Sri Lanka, and it can also give an understanding of the severity of the disorder. It's able to screen for comorbid ADHD along with bipolar disorder. So the tool has 65 stems, and it has separate domains for DSM diagnosis of mania, depression, as also anxiety. It identifies cognitive deficits related to bipolar disorder, identifies circadian rhythm disturbances, appetitive drive disturbances, and also other neurodevelopmental deficits. So Going forward, I think it's high time we go beyond adult experience-laden classifications. High time that we go beyond phenomenological classifications to more biological classifications. Then the importance of early diagnosis and management cannot be emphasized, as also perinatal mental health and infant mental health realms to be considered, especially in parents with psychiatric illness, where the genetic vulnerability sits in to reduce the burden to transmit the illness across to the next generation. Thank you.
Thank you, Dr. Nilanja, for that very illustrative presentation. We will take up the questions at the end of the session, and we'll move on.
Our next speaker is Dr. Yashoda Rohana Chandra, Consultant Child and Adolescent Psychiatrist, Colombo South Teaching Hospital, and Senior Lecturer, Department of Psychiatry, University of Sri Jayawardhanapura. She has completed the Certificate of Advanced Training in Child and Adolescent Psychiatry from the University of Melbourne, and she is the editor of the Sri Lanka College of Child and Adolescent Psychiatrists. She has been involved in several national level capacity building programs with the Ministry of Health, Family Health Bureau, Department of Education, and the National Child Protection Authority. More than 30 publications in local and international journals she has published, and authored a book chapter on depression in mothers and mental health in their children. The book is Impact, Risk Factors and Interventions in the Neuroscience of Depression. Over to you, Yashoda. Thank you.
Thank you, madam, and good evening, everyone. And first of all, thank you for giving me the opportunity to talk at this session. Right, so I'll be talking about the impact of depression and mood disorders and parental mental illness on children. And so when we see mothers with depression or any other psychiatric illness, in a busy clinical setting, we focus mainly on one thing, about the risk, whether there's a risk of infanticide, filicide, is there a risk of abuse, or is there a risk of neglect. But there is a huge amount of literature that shows children of parents with mental illness, that risk of developing a lot of negative psychosocial consequences that we often do not look into in our clinical setting. So literature shows that of children of parents with mental illness, about 35% need referral to education and psychological services, about 7% need referral to family services, and an extremely high amount, almost 40%, need treatment from child and adolescent mental health services. And children of mothers with depression, they are at higher risk of developing depression as well as other psychiatric and social problems compared to the general population. And this is not due to the increased genetic risk per se. So these children of parents with mental illness, have often been labeled as invisible children because they have a high risk of developing psychosocial problems, but they are underserved by the mental health care system. This is because we know children do not seek services, mental health services on their own. They are usually brought by their parents. And if the parents are struggling with their own mental health issues, they will not see the changes or acknowledge the mental health needs of their children. So because of this, these children rarely present to the services. But the good news is, if you provide family-friendly services, family-focused services to the parents and the family, it can reduce the impact on children for about 40%. Right, so we'll go into the details of effects of maternal depression on mental health of children. So as we all know, it starts with the effect on mother-child bonding. So there is research that show that even mild or unrecognized depressive symptoms in the mother during the first 4 months after birth can cause disruptions in bonding. And they have found that there is no relationship between mother's depression and attachment after the initial 4 months. So this suggests that bonding has a window of opportunity, that it develops best within the first 4 months. So this is why we need to identify and treat maternal depression early, because if we detect it late, the window of opportunity to develop the bonding has already passed. And then the effect of attachment. So infants and preschoolers whose mothers have been depressed, they have lower rates of secure attachment, and they are at higher risk of developing insecure, avoidant and disorganized attachment. And this is mediated through the effect of the maternal sensitivity. So we know that attachment develops through responsive caregiving. So responsive caregiving is the mother should identify the child's needs and respond appropriately. So when the mother is having depressive symptoms, due to her own issues with emotional regulation, she may not be able to provide responsive caregiving. So for example, when an infant cries, the mother picks up the child and feeds the child or consoles the child. But if the mother is depressed and the child is crying, the mother might be irritable or shout at the child instead of providing the consoling the child. So this may cause attachment difficulties in the child. And then an aspect that we do not consider usually, maternal depression can actually interfere with child development through several mechanisms. So first of all, mothers who are having depression, they are less able to stimulate their children, and they are not able to provide an early learning environment. And also they do not provide exploration as much as parents who are not depressed. And also they have diminished motivation to engage in play with their children. So we know play is the main way children gain stimulation in the early years. So all of these factors contribute to poorer developmental outcomes in children. So research shows that there are delays in all domains of development, and there are development delays in up to 11.8% of children in mothers with depression. So fine motor delays are increased by 4-fold, emotional developmental delays are increased by 6-fold, and there is also poor cognitive functioning in infancy and adulthood. And actually this poor cognitive functioning can last for long term, because a study they have done on 16-year-old boys have found that at that age, at 16 years, children whose mothers had postnatal depression, they had poorer cognitive scores compared to children whose mothers were not depressed. And also they have found that children whose mothers were hospitalized for mental illness during the preschool years, they are less likely to be school ready. So although we neglect this aspect, there's a huge impact of maternal depression on child development. And then maternal depression can actually cause sleep disturbances in the child. So from early life up to adolescence. So this is mediated by several mechanisms. So parents with depression, they have difficulty in setting sleep-wake routine. So we all know that it's sometimes difficult to get a toddler to sleep. So if the mother is depressed, they have difficulty in enforcing these bedtime routines. So as a result, the child may actually go to sleep later. And also, children tend to get distressed at bedtime. And because the mothers with depression, they have difficulty in regulating their own emotions, they tend to be more depressed at the face of their children's distress. So they are more likely to be involved during their child's bedtime, and because of that, the infant's ability to self-regulate to sleep becomes less. And of course, children of mothers with depression, they are more likely to be physically aggressive. And also the presence of maternal depression is a predictor of children with ADHD developing conduct problems. And also there is increased risk of loud, rowdy behavior, alcohol use, and bullying among young males whose mothers are depressed. And of course, they are at more risk of developing internalizing problems. And some of this is related to the mother's illness itself, because they might feel afraid and anxious about the mother's illness. And we know that young children often tend to blame themselves for the problems of the family. So these young children often blame themselves for the mother's illness. And we know our culture also tends to blame the children's behavior. You know, it's because of you, your mother has got sick, right? So this itself can cause an added burden to the children. And of course, they may have, especially young children, they have difficulty in understanding mental illness, why their mother's behavior has changed. And they might fear that the same thing could happen to them. And older children, especially adolescents, may feel embarrassed about their parents' behavior. And so children whose mothers are depressed, they have higher risk of internalizing problems from preschool years up to early adulthood. And maternal depressive symptoms during preschool years is associated with emotional problems, separation anxiety, and social withdrawal. And during adolescence, it has increased risk of depression and anxiety disorders in the adolescents. So these internalizing problems are actually mediated through the effect on parenting. So mothers who are depressed, they are more likely to use psychological aggression during parenting. So they are more likely to yell and scold and label their children, call names. So that can predispose to internalizing problems. And also they are more likely to emotionally reject their children. And they have fewer positive interactions with their children because they are, like I mentioned earlier, they are less motivated to play and engage in positive interactions. And also they have a higher degree of negative interaction and conflicts with their children. So all of these can lead to higher rates of internalizing problems in children. And also children of parents with depression, they are more likely to have at a higher risk of developing suicidal ideation, and especially where the mother has chronic and severe depression. And it's interesting that the children may have a higher risk of suicide even when the child is not depressed. Even when the child themselves is not depressed, they still have a higher risk of suicide if the mother is depressed. And then there are social effects. So this is one of the commonest social effects we see, parentification. So children of mothers with any mental illness, not just depression, they have more responsibility at home compared to children of the same age. They may need to monitor the parents' medication, they may be responsible for the younger siblings or the household chores. So they have less time to engage in normal age-appropriate activities, to engage with peers and schoolwork. So it may impair the child's social development. So this is a study we conducted in Sri Lanka to assess the impact of maternal depression on children using the SDQ. And we found that actually 14% of children have had abnormally high levels of hyperactivity, and 13% conduct problems, 12% emotional problems, and overall 10% met criteria for abnormal total difficulties in the SDQ. Right, so we'll go to the risk factors, because all children with mothers with depression do not develop equal negative psychological consequences. So low socioeconomic status of the family is a risk factor because they have fewer resources and also low educational attainment. So if the mother has low educational attainment, they are also likely to be of poor socioeconomic service, have less resources. So all that can contribute to increased risk of psychological problems in the child. And the age of the mother. It has been shown that mothers at the extremes of age, younger mothers and very older mothers, children of younger mothers and older mothers, are at more risk of developing psychological consequences. So if we take the younger mothers, because of their younger age, they may not have the maturity of older mothers, and their coping skills may not be developed yet to the fullest capacity. So because of that, when they are depressed, they might have a difficult time coping with it. And older mothers, at the other end, they may have a lot of physical comorbidities. So because of that, they might be tired anyway. And on top of that, when they get depression, they might find it more difficult to cope. And age of the child is again a very important factor that has been identified. And younger children develop more psychological consequences if the mother has depression than older children. So there are several reasons for this. One thing is younger children are more completely dependent on their mothers, whereas older children, they have other contacts outside of home. They have friends, they have teachers, they are able to seek help from other relatives. And also, younger children, they are not able to understand that the mother's change of behavior is due to an illness, whereas adolescents and older children may be able to understand that this change in behavior is due to an illness. And the gender, they have found that boys are more likely to develop, have an impact on cognitive development, while girls are more at risk of developing internalizing problems. And of course, parents of single parent households, those children are at higher risk, as well as if the father has also a mental health problem or alcohol or substance use problem, and where there's a large family size. So then the attention anyway that can be given to a single child is less, and especially when the mother is depressed. So there are certain illness factors. One is the chronicity of depression. So if the mother has been depressed for a longer time, the children have a higher risk of having psychological problems. And the severity of depression. So actually lots of studies have shown that when the mother is moderately depressed, the effects on children is more than when the mother is severely depressed. So they have hypothesized that when the mother is severely depressed, it's easily noticeable by others. So other relatives, the father, and so they step in to help, and the extended family may help. So because of that, it may mitigate the effect on children. And also when the mother is more severely depressed, the child may be able to understand, more able to understand that this is an illness. Whereas a moderate depression, the child may not realize that this change of behavior is due to an illness. So because of both these factors, moderate depression is thought to affect children more than severe depression of the mother. And also the presence of comorbid illness in the mother. And there are certain resilience factors. Like if the child has high IQ, it's a resilient factor, and also the quality of the parental support relationship and the support from the co-parent. So if they have good parental relationship and good support from the father, the risk of children developing negative consequences is less. So as I mentioned, mother's depression has a big effect on parenting. So they are more used to mothers who are depressed are more likely to use harsh discipline, like they are more likely to slap and yell and use physical punishment. And they are less likely to use positive parenting strategies like rewarding, and they are less likely to talk and problem solve with their children. And they have less positive interactions, as I mentioned. They are less likely to play games. And mothers with depression have difficulty in maintaining daily routines because they are preoccupied with their own mental illness. And they have difficulty in organizing daily activities, and they also are more likely to worry about their children. And they are less emotionally available, and sometimes they may find it difficult to enforce rules and maybe lax in their parenting styles. And usually their mother-child interactions are characterized by lack of warmth. Right, so what can we do about this is what I'm going to talk about last. So the first thing that we need to do is screening the mother for depression. So it is recommended that all women during pregnancy and postpartum need to be screened for depression. And we can use the Edinburgh Postnatal Depression Scale, which has been validated in Sinhala and English, and Sinhala and Tamil, and is quite easy to use. An effective treatment of the mother. So I just mentioned that the chronicity of the depression is associated with higher psychological impact. So because of that, we need to treat the mother early. We need to get her into remission, and this study, the study trial child arm, that has shown that when the mother's depressive symptoms remits, the child's internalizing problems, externalizing problems, and total symptoms, everything improves independent of the child's age, sex, baseline severity of the problems, and the socioeconomic status. So treatment of the mother, remission of the mother itself reduces the psychological impact on the children. And screening for psychological problems. So in adult mental health services, you need to ask the parental status of the patient. and routinely ask mothers about concerns of their children. So simple questions like, is their child going to school? Are they having good school performance? Are they having any behavioral problems? A few questions like that you need to ask from the mother, because we know they might have, these children have a higher risk of developing psychological problems. And we also can use screening instruments like SDQ or SNAP4 to screen these children. And in the child and adolescent mental health services, we should do the opposite. Actually, when a child presents with mental health problems, we should screen the mother for depression. So, because we also find that the mother is also depressed. And high quality child care. So they have shown that high quality child care can actually reduce the impact on children. So without spending the entire time, younger children especially, with the mother who is depressed, if they can find alternative child care which provide early stimulation, adequate stimulation and warmth, that reduces the impact on children. So in Sri Lankan setting, we can use the extended family to provide this support, provide stimulation and warmth. And school-based intervention. So they have they found that classrooms with warm, positive environments, children in these classrooms, they are less likely to be affected by their mother's mental illness. So because of that, liaison with the teacher and arranging extra support for the child is important. And crisis care planning. So sometimes the severity of the parent's mental illness may impact their caregiving capacity. And if the parent is admitted in the hospital, they no longer can look after their child. So a study we have done in Colombo South Teaching Hospital found that if one parent received inward treatment, 53.4% of the children have not engaged their routine day-to-day activities such as schooling and extracurricular activities during that time. So if the mother is hospitalized for 1 month, the child may miss school for 1 month. So that is why we need a crisis care planning. So crisis care planning is in high-risk patients who we think might need admission or might have impaired parental capacity. We need to identify another adult who is able to look after the child. If we shouldn't wait till the mother is actually admitted. We should have that plan. Who's going to look after the child? And this identified person should have the child's normal routine. They should know, so that the child's daily routine is not interrupted when the mother is at the hospital. And sharing age-appropriate information is also needed, because the child is more likely to blame themselves for the illness if they don't know that this behavior change is due to actually an illness. And also children tend to imagine the worst outcome. So if the mother is admitted to the hospital, they might think that the mother might die, may not come home. So sharing age-appropriate information with the child is important to reduce the impact. And also encourage social relationships with peers, encourage outdoor activities, and encourage relationships with other adults. And link with community services. So in our community, if the mother is depressed, we can communicate with the PHM and the MOH and arrange extra support, maybe more home visits, more frequent screening for developmental delays and parental support. And also we can arrange more supervision through the Child Rights Promotion Officer at the AG office. We can get them to do home visits and provide extra support. Right, I'd like to leave you with this quote I found. The first 5 years have so much to do with how the next 80 turns out. So by treating maternal depression effectively and by using family-focused interventions, we can change this first 5 years or the early childhood, which can have a lasting impact on the rest of the child's life. Thank you.
Dr. Yashoda, for that thought-provoking lecture, which is relevant for both adult and child psychiatrists in this country. And I hope Dr. Sharma is still with us. And I would like to invite Dr. Yashoda Rohanachandra and Dr. Nilanja both to come to the stage. And I think there are 2 questions for you. One question, right?
Have they done any studies on effects of father's mental illness affecting child's mental illness?
It's for you. The effect of father's illness actually is far less studied, but they have found the general effects like in the parentification and sort of disruption of daily activities. Those effects are similar to mother's depression, but generally the mother's illness would have a higher impact on children than the father's illness they have hypothesized, because mother is usually the primary caregiver, especially in our community.
Due to the time factor, we will allow one more question from the audience.
I have one question to Dr. Nilanja. These children with bipolar disorder, when they become adults, are there any follow-up studies whether the disease profile is the same or whether they'll reach the normal adult bipolar profile? Do you know about any research on that?
So yes, madam. So according to one of the studies that I showed in the presentation, they have actually found that the stability of the diagnosis, they do go on to, they convert to either bipolar 1 or 2, and they found that the same disease burden and the functional impairment has been same across life.
Okay, thank you very much. Since there are no other questions, I would like to thank the three speakers, Dr. Sharma, Dr. Nilanja, and Dr. Yashoda for the excellent presentations. And I would invite Dr. Swarna to award the certificates to the two speakers here, Dr. Nilanja and Dr. Yashoda. And Dr. Sharma, yours will be an e-certificate, and you will receive it. Thank you very much for joining with us this evening. Thank you.
So that brings us to the end of day one of our annual academic sessions. And thank you all for your participation. We look forward to meeting you all tomorrow at 8 a.m. for yet another day filled with interesting lectures and events. Thank you and have a good day.